ladies and gentlemen. We are now going to move on to the final symposium for the day, and it is on endocrine surgery, specifically on safe thyroidectomy. This session will be run by Dr. Mihira Bandara, who is a consultant general surgeon at North Colombo Teaching Hospital, and also by Dr. Amila, who is a consultant general at Teaching Hospital, Agarwal. Over to you, sir.
Thank you. Good evening, everyone. We have come to the final symposium for the day. It's on endocrine surgery. So, the commonest endocrine surgery being performed is thyroidectomy. To talk to us on thyroidectomy today, we have three experts from South Asia. To introduce to you the first speaker this evening, I invite my colleague, Dr. Mihira Bandara.
Good evening. Next speaker is Professor Amit Agarwal. He is Professor of Endocrine Surgery, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, India. He is the current President of Indian Thyroid Society and former President of Indian Association of Endocrine Surgeons. And he is the Editor-in-Chief of the World Journal of Endocrine Surgery. Over to you, Professor Agarwal.
Good evening, ladies and gentlemen. At the outset, I'd like to thank the college for inviting me to share with you our experience with preservation of parathyroids during thyroid surgery. The task given to me today is to talk about the in situ preservation of the parathyroids. So I'd like to divide my talk into causes of hypoparathyroidism, the mechanism behind it, what the techniques the surgeon must employ to preserve the vascularity of the parathyroids, and some recent advances which helps the surgeon to preserve the parathyroids. We all know Theodore Cocker as the father of modern thyroid surgery, and it is interesting that the principles described by him are still valid and have become the foundation of all future refinements in thyroid surgery. The change that has taken place is that now the more emphasis is on giving better cosmetic results, prevent recurrences, and prevent complications, particularly injury to the parathyroid glands, which causes hypocalcemia. Despite all meticulous technique adopted by the surgeons, hypoparathyroidism is still the most common complication of bilateral thyroid surgeries, and the incidence can range anywhere from 20 to 40%, sometimes even in the best hands. If you look at the risk factors for hypoparathyroidism, two important factors I'd like to emphasize. One is the central neck dissection, either prophylactic or therapeutic, and the other is the surgery by a low volume thyroid surgeon. The mechanisms that underlie the hypoparathyroidism are related to disruption of the parathyroid arterial supply, which may be venous as well, mechanical injury to the parathyroid glands, thermal injury, especially with the use of new energy devices, and most importantly, inadvertent, partial or complete removal of the parathyroids. The short half-life of parathyroids, along with the fragile nature of the parathyroid glands, sets the stage for their functional derangement following manipulation. Thus, it is critically important for the thyroid surgeon to employ strategies for minimizing and preventing hypoparathyroidism. However, the objective of preserving all four parathyroid glands may not be attainable because of the anatomical locations and variations in the blood supply of the parathyroid glands. But the most important thing is to accurately recognize the parathyroid tissue. And if you see this paper, it has clearly emphasized that in situ preservation of the parathyroid glands would lead to reduced incidence of hypocalcemia. So that is mandatory to make all the efforts to preserve the parathyroid glands in situ. If you look at this paper from Memorial Sloan Kettering, US, it shows that the incidence of inadvertent removal of parathyroid glands during thyroidectomy ranges up to 20%, depending on the surgeon's experience and the type of the surgical procedure. This paper explored the relationship between hypoparathyroidism and the number of parathyroid glands preserved during thyroidectomy. And the authors emphasized that at least one parathyroid gland with an intact blood supply is sufficient to prevent permanent hypoparathyroidism when autotransplantation is not performed. Thus, it is interesting that it is not essential to visualize all the 4 parathyroid glands. In another study by Thomas et al., they demonstrated that at least 2 parathyroid glands should be identified and preserved in order to avoid permanent hypoparathyroidism. And interestingly, it is preservation of inferior parathyroid glands is more likely during thyroidectomy as compared to the superior parathyroids. As I mentioned, it's important to identify the parathyroid glands, but it will not be very easy always because they vary considerably in size, shape, number, and location. And this wide variability represents a unique challenge for the surgeons. Secondly, they are difficult to distinguish from the other cervical tissues, such as fat and lymph nodes, because of the small size and similar color. So the time-honored key to parathyroid identification has been a very proactive, anticipatory visual approach and use of surgical landmarks. It's good to remember that the consistency of lymph node is more firm than that of the parathyroids, and lymph nodes are slightly more grayer as compared to the parathyroids. It's also essential for the surgeons to know about the vascular supply of the parathyroid glands, but because it is important to save an intact parathyroid glands with an intact blood supply as well. It's important to remember that the normal parathyroid gland is composed of 30% capillary cells. Parathyroid's blood supply is both delicate and complex and requires close attention during thyroidectomy to ensure its preservation. The main blood supply of the inferior parathyroid glands is the inferior parathyroid artery, which arises from the inferior, which is a branch of the thyrocervical trunk. The superior parathyroid gland also receives its blood supply from the inferior parathyroid artery, but occasionally it may derive its blood supply from the anastomotic loop between the superior and inferior thyroid arteries, and sometimes, very rarely, exclusively from a branch of the superior thyroid artery. But it's important to remember, and it has been shown by the laser Doppler flowmetry studies, that the superior thyroid artery and vessels within the thymothyroid cord can dominate in some individuals. So it may not be that blood supply is always from the inferior thyroid artery. And this is a paper which showed that if you occlude the main trunk of the inferior thyroid artery, the blood flow is reduction by only 1/3 of the control values, and indicates that parathyroid glands are only partly dependent on the blood supply from the artery. One important source of the blood supply is the connective tissue, vessels in the connective tissue between the parathyroid glands and the thyroid lobe. And as I will share with you later in the talk, this is sometimes a very difficult proposition to save this blood supply. This paper from Korea explored various means to reduce post-thyroidectomy hypocalcemia. And the authors mentioned that the parathyroid artery to the parathyroid gland is a typical end artery. The blood supply is not very simple. And the authors also emphasize that the parathyroid gland receives the blood supply from adjacent vessels in the connective tissue located on the surface of the thyroid gland. One interesting paper proposed that it is the preservation of the inferior thyroid vein that can help reduce the incidence of transient hypocalcemia. And therefore, it's very important to preserve the inferior thyroid vein. As you can see in the diagram, never to ligate the inferior thyroid vein here, but to ligate it here so that you preserve the lower portion of the inferior thyroid vein which drains both the superior and the inferior parathyroid glands. So even if you have preserved the arterial supply, if you have not preserved the inferior thyroid vein, the parathyroid glands would become congested and would not function very well. One controversial aspect which is always discussed is whether the inferior thyroid artery should be ligated. But more studies have now shown that the truncal ligation is to be avoided because it increases the risk of temporary asymptomatic hypocalcemia, even if it does not reduce the risk of permanent hypocalcemia. So the concept that is proposed for a safe thyroidectomy is a capsular dissection, which has 4 components, and one of the important components is the parathyroid preservation. And what you mean by capsular dissection is that you ligate the small terminal or the tertiary vessels of the inferior thyroid artery, which lie on the surface of the gland, rather than the main trunk or the secondary branches. So a gentle capsular dissection that reflects the perithyroidal fatty tissue off the surface of the thyroid allows the preservation of blood supply. As you can see, this is the superior parathyroid and this is the inferior parathyroid. As I mentioned, some important landmarks can also help you to identify the parathyroid gland. And one of the important landmarks is the tubercle of Zucker candle. And tubercle of Zucker candle always points to the presence of a superior parathyroid. So that's a helpful landmark for the surgeons. A word about autotransplantation. Sometimes the parathyroids are inadvertently removed. So always check the specimen. If you find a parathyroid gland, you excise it. Then you mince it in saline into very small pieces. And then with a wide bore needle, you can inject it into the sternocleidomastoid. So it takes only a few minutes. There have been some recent advancements in the techniques of parathyroid identification. And one of the important techniques is to use the agents, photosensitizing agents like indocyanine green, aminolevulinic acid, methylene blue, etc., which helps to detect the parathyroid glands with the near-infrared fluorescent imaging. Besides this, the latest technique is the use of autofluorescence. So instead of using any photosensitizers, you use a near-infrared fluorescent spectroscopy in around 820 wavelength. You can actually, the parathyroids start to autofluoresce, and hence can be detected. So you don't need to use any external dye or sensitizing agents. So I'd like to conclude by saying that the individual surgeon should strive to recognize their own rates of hypoparathyroidism and minimize this complication through the measures reviewed. Thoughtful preoperative assessment, meticulous intraoperative surgical technique, as I mentioned, saving both the arterial and the venous blood supply of the parathyroid glands, and potential use of technical adjuncts, especially like infrared detection and prompt diagnosis and judicious treatment would minimize and eliminate the risk and negative consequences of hypoparathyroidism. I thank you once again for your patient here, and I'm happy to take any questions from you.
Thank you, Dr. Agarwal. Our next speaker is Dr. Roma Pradhan from India. She's the Assistant Professor and Head Department of Endocrine Surgery. She's a specialist endocrine and breast surgeon in India, and she has authored over 30 peer-reviewed articles and book chapters. She's the editor of the prestigious World Journal of Endocrine Surgery, and she's going to talk to us on another important aspect of safe thyroidectomy, that's preserving the nerves. Over to you, Dr. Pradhan.
A very good afternoon to all. At the outset, I would like to thank Professor Ranil Fernando and the organizing team for giving me this opportunity to share my experience on preserving the nerves in thyroid surgery, especially the recurrent laryngeal nerve. What happens when you tend to damage one of the recurrent laryngeal nerves? Hoarseness of voice. And what happens when you damage both the nerves? There is no voice and the patient lands up in permanent tracheostomy. So why is it important to preserve the nerves? It's because of this clinical impact on the surgeon, the economic and the social cost involved, the quality of patient's life, and also the medico-legal litigation. We know that permanent recurrent laryngeal nerve palsy rate is less than 1%, but this is in experienced hands. Before we dive into the methods to preserve the nerve, we need to know the anatomy of the recurrent laryngeal nerve and also the variations in its anatomy. We know that the right recurrent laryngeal nerve loops around the right subclavian artery to enter the neck, whereas the left one loops around the aortic arch to enter the neck. The point that needs to be noted here is that the right recurrent laryngeal nerve enters the neck little more laterally as compared to the left one. And hence we need to keep this in mind while we are operating. Right non-recurrent laryngeal nerve is the most common variation that we encounter. Hence, we should not transect any structure unless we have identified the recurrent laryngeal nerve. Now, there are various methods to identify the nerve and also to locate the nerve. These are the visualization methods, methods to expose the nerve, the palpatory method, and neuromonitoring, the newer adjunct. Before getting into those specific methods, we need to know some general identifying features. These are proper exposure of the field. No structure should be transected unless the nerve is identified, preferably a bloodless field. Nerve is white in color and has a wave-like profile and a vascular strip or vasa vasorum over it. So it seems like a toothpaste sign. And when you palpate, it feels like a cord. Now there are various methods to expose the nerve. Lateral, inferior, and superior. Lateral is the most common. In lateral approach, we first dissect the superior pole, the inferior pole. We also dissect the inferior parathyroid of the inferior pole, and then we deliver the thyroid out. And we retract it medially, retract the strap muscles laterally, and then try to palpate the nerve in the tracheoesophageal groove. So we palpate the nerve in the tracheoesophageal groove with a finger. You feel it like a cord-like structure. And then where you feel it like a cord, you just dissect it with your artery. This inferior approach is ideal for routine thyroidectomy. In large cervical goiter or in cases where tubercle of Zuckerkandl is well developed, this area may not be exposed adequately for RLN identification. Hence, we have the inferior approach. In inferior approach, the RLN is identified in the RLN triangle or the triangle of Lohr, which is bounded medially by trachea, laterally by the common carotid artery, and superiorly by the inferior pole of the thyroid. The only disadvantage in this approach is that a long segment of RLN needs to be dissected out. And also there are more chances of devascularization of the inferior parathyroid. Then we have the superior approach. RLN, we identify the RLN at its entry point, that is at the ligament of Berry. This is the most constant point in the neck. We use this method when other methods have failed. This is one of the difficult approach to identification of the nerve because there are more chances of damage to the nerve as the ligament of Berry is fibrous and it can bleed. Now I will demonstrate some of the cases which I encountered of difficult nerves. A 20-year-old girl, FNAC PTC, the vocal cords were mobile preoperatively. This was the nerve and this was the lymph node which was stuck to the nerve and was difficult. I had a difficult time in dissecting the nerve out. Another lady with the FNAC of PTC, intraoperatively there was extrathyroidal extension and the nerve was densely adhered to the tumor. Postoperatively, patient had hoarseness of voice, which recovered after a period of 1 month. This was a recent case which I operated. The nerve was pushed up with a group of central compartment lymph nodes here. So nerve was pretty high up in the neck. So while operating on these cases, I did have a thought. I wished I had used neuromonitoring in these cases. As the literature suggests, that neuromonitoring should be used in selected cases like difficult goiters, big goiters, or reoperative cases. But the point is, we actually do not know when we will encounter these difficult nerves in which we may require help of neuromonitoring system. So let's see what are the advantages of intraoperative neuromonitoring. It's especially useful in higher risk patients of locally advanced thyroid cancer, reoperative surgery with enlarged goiters, prevents visual misidentification, and also prevents bilateral recurrent laryngeal nerve injury by allowing the surgeons to stage the surgery when the signal is lost on the initial side and hence avoiding tracheostomy. It also increases surgeons' confidence. Several investigators have suggested that low volume thyroid surgeons may benefit from intraoperative neuromonitoring. Now there are two types of neuromonitoring. One is the intermittent and one is the continuous. So in intermittent neuromonitoring, we give signals, we stimulate the nerve The signals are captured by the electrodes, which are there in the endotracheal tube itself, and which is then transmitted to the monitor as waveform. So intermittent means that for the majority of the intraoperative time, we do not hear what the nerve has to say. And hence, a newer form, that is the continuous neuromonitoring, came up. So that is the real-time monitoring of the nerve status, and it also helps us in knowing the post-operative function of the nerve. So this is the apparatus for continuous neuromonitoring. The only difference here is the vagal electrode. So I'll just show you a short video demonstrating the continuous neuromonitoring. This is the intubation of the patient. The tube that we use is with the electrodes. This is a special tube that is being used. This is the monitor, head and neck, thyroid with APS. Here, once all the ticks are here, so we know that the endotracheal tube has been placed perfectly in the trachea. So next step is identification of the vagus and then freeing it, dissecting it all through 360 degree and applying the vagal electrode over the vagus. The one thing that you need to remember is the dissection should be done in the lower part of the vagus, since you need to avoid damage to the non-recurrent laryngeal nerve if it happens to be there. So this is the placement of the vagal electrode. So once you place the vagal electrode, you see these waveforms coming while you are operating on the patient. So I'll just explain you this part. This is the normal waveform. The red line here shows the latency, the limit for the latency, and this the lower down is the amplitude. So when the waveform goes beyond this part, that is a fall in the amplitude of more than 50%, that is significant, and any latency which is more than 10%, that is significant. So when that happens, the machine sets an alarm to you so that you can listen to that alarm. So I'll just show you that. So this is the alarm that happens when you either stretch the nerve or there is thermal injury to the nerve. So you need to step back, wait for some time for the wave to come back to normal. Now coming to the systematic review and meta-analysis comparing the intraoperative neuromonitoring versus visualization. In this review, they showed no significant benefit of IONM over the visual identification in the rate of RLN palsy. However, a subgroup analysis conducted by Drull et al. Showed a significant reduction in the incidence of permanent recurrent laryngeal nerve palsy in low volume surgeons who adopted IONM during thyroidectomy. This is another study comparing continuous with the intermittent neuromonitoring. This study did show a significant reduction in transient and a non-significant trend towards the lower risk of permanent vocal cord palsy while using continuous neuromonitoring. It's a very interesting table showing the benefit of continuous neuromonitoring over the intermittent and visual. We can see here, it helps in minimizing traction injury, avoidance of thermal injury. It's a real-time functional monitoring, and there's detailed EMG documentation. So to conclude, I would like to stress upon that we need to protect RLN during the entire course of a thyroidectomy. So it should be done under perfect visual control while we are ligating the individual branches of ITA in order to avoid damage. During the successive separation from the nerve of the branches, while looking for the tubercle of Zucker-Candle, and also in the final separation of the thyroid lobe from the ligament of Berry. And we can use neuromonitoring in selected cases. So a happy patient leads to a happy doctor. Thank you so much for your patient listening.
Thank you, Dr. Pradhan, for your excellent speech on preserving nerves during thyroidectomy. We'll move on to our next speaker. He's Professor Ranil Fernando. He's a senior professor of surgery, Faculty of Medicine, University of California, consultant surgeon, North Colombo Teaching Hospital, Ragana. He's a past president of College of Surgeons 2013, and former chairman of Board of Surgery, PGIM. Over to you, sir. He's going to deliver on redo thyroidectomy.
Thank you, Mr. Chairman, for that kind introduction. I just would like to say hello to my friends Roma and Amit in India. I hope you all are keeping well. And my task this evening is to talk about reoperative redo thyroidectomies. And I'm grateful to the organizers for the chance given to do this. The first question that comes to mind is, why operate on the thyroid gland again? Well, and there are many problems with this. And how does one avoid problems? And what is the best surgical strategy? So these are the areas that I'm going to concentrate on this evening and discuss with you. Why operate on the thyroid gland again? Broadly speaking, it is for recurrent disease of the thyroid. Now, this may be due to benign disease, such as incomplete removal of a multinodular goiter, which is a remnant from the past, because the operation previously was a subtotal thyroidectomy, which was fashionable. And then the hemithyroidectomy has been done for some reason, and the other side has grown, or there has been recurrences from the embryological remnants, which were not emphasized once upon a time. In malignancy, for a follicular carcinoma particularly, we might have to do a completion thyroidectomy. And also thyroid bed recurrences need to be removed. And also sometimes we have to do a second operation to clear lymph nodes in relation to the thyroid. So these are the main reasons why we would have to reoperate on the thyroid. What are the problems? The problems are, this is a technically challenging operation because of various things like fibrosis, scarring, altered anatomy, etc. And the complications. I'm grateful to my two friends who had touched upon this previously. Injury to nerves, damage the parathyroids. Amit has told you about how to avoid them. And there are other complications like chylus fistula, which are rare. But I firmly believe that patients should not be denied the chance to undergo removal of persistent tumor or a large recurrent goiter because of fear of complications. We must recognize them, but should not be afraid to operate. How does one avoid problems? I think this is something that I would like to emphasize. Reoperative surgery is only for the experienced surgeon. Then you might ask me, who is that? These are some accepted criteria for experienced surgeon. Must do thyroidectomies regularly. What do I mean by that? You must do at least 50 to 100 thyroidectomies a year. So that means once a week at least. And acceptable recorded rate of complications, around 1 to 2%, both nerve and hypothyroidism a little higher, parathyroidism a little higher, but nerve injury certainly less than 1%. Preferably, an endocrine surgeon or somebody with special training in endocrine surgery. So these are the, and in my view, it should be done only in a tertiary care center because of the enhanced facilities available in such a center in case of complications. And this is my personal experience again. I think if you're going to do reoperative surgery, it is best to use some sort of magnification. And my personal preference is to use surgical loops, which have helped me a great deal. And here, you can do it for bilateral disease. You can see all these people have had thyroidectomies before, but you can see the recurrences. And for unilateral disease. Or here are the recurrences in the embryological remnants. In these patients, it is primarily the pyramidal lobe. When you operate, you'll be surprised. Now, this lady is supposed to have had a thyroidectomy, but you can see the specimen that we have removed. And here's another patient. It looks as if all the entire thyroid has been left behind. These are mostly probably from embryological remnants, but part of the thyroid also has been left behind in the previous operation. I'm sure you can see the scars in the neck in both these patients. What about the best operative strategy? Well, reoperative surgery is difficult, so approach with caution. May I please say that? Difficult to approach the thyroid in the midline because of scarring and fibrosis. So our personal preference you can re-explore the, you can use the same incision and on the skin and go down, but we prefer the lateral approach because it is, in our view, much better. The key to lateral approach is to develop the plane between the sternomastoid muscles and the strap muscles. And the advantages are, you are operating in undisturbed territory. Laterally, nobody has approached the thyroid. And you have direct control of the veins, lateral structures like the veins, and also good access to the thyroid, and not only laterally the veins. I think Roma has mentioned the recurrent laryngeal nerve also can be nicely accessed from the lateral side. So lateral approach has many advantages. So our personal preference when we do reoperative thyroid surgery or redo thyroidectomies is to do the lateral approach. And here you can see the sternomastoid and strap muscle separated and very clear access of the thyroid. You can do it unilaterally, or as in the second patient, bilaterally. You can do this approach. And see the access, it is excellent. And laterally you can see quite good clearance. And even the embryological remnants right up in the neck can be approached with the lateral approach. What are the special issues? Again, these have been touched already. Abnormal anatomy. Non-recurrent nerve, which Roma has spoken to you about, particularly on the right side. You can see the non-recurrent nerve on the right side and the vagus nerve at the bottom. And if you are not aware of this and you're doing a lateral approach, you might get into trouble. So you need to watch out for this. And neuromonitoring. Roma again spoke about this, but in summary, no clear advantage in routine use. And I think she also mentioned selective use. And this is something that I firmly believe in. Even proponents of intraoperative neuromonitoring agree that visual identification of the nerve is the gold standard. I want everybody to remember that you must see the nerve. However much you have a monitor, you can cut it at different places and get a signal still. But unless you see it clearly, you're going to damage it. In difficult reoperative thyroidectomies, yes, sometimes you wish you had a neuromonitor to know exactly where the nerve is. Perhaps there is a role for neuromonitoring in a patient like that. But remember, you have to remember the cost effectiveness and remember it's a difficult learning curve because it's a new technology. What about the parathyroids? Amit touched on this. Here are the two parathyroids that you see and the nerve in the middle. So it's very important. Superior one is just behind and the inferior one is in front of the nerve. So you need to identify in that brown colored structure, the typical brownish color that you need to identify. There we are. You can see them. And Amit again mentioned this. I think one of the techniques, if you are particularly doing reoperative thyroid surgery, is to learn about auto-transplantation of the parathyroid. You mash it up into small bits, mainly for the blood supply, and you take it into a syringe, and then you need a large bore needle, and you can directly inject into the ipsilateral sternomastoid muscle, and that's quite effective. And this is a fairly easy procedure which we practice very often. And to conclude, I would say that redo thyroidectomy is a challenge. Surgery should not be denied in view of complications. Careful preoperative assessment is essential. Meticulous surgical technique is the key and lateral approach is recommended. Neuromonitoring, I think there's a little doubt about that, but I think it might help in some patients. Reoperative thyroid surgery can be done safely, particularly by experienced people, and acceptable complication rate is an essential thing. And I would personally recommend the use of optical loops. Thank you very much. And here are some pictures from Sri Lanka. Thanks a lot.
Thank you very much, sir, for that excellent talk on another challenge of safe thyroidectomy, redo thyroidectomies. Now we have read the question and answer session. Just one question is, what is the best anatomical location for reimplantation of inadvertently removed parathyroid? I think.
Yes, good evening.
So as I mentioned, the best site is the sternomastoid, which is already exposed on the ipsilateral side, from where the parathyroid is inadvertently removed. Unlike in familial cases where you implant the parathyroid remnant or a small tissue in the brachoradialis. But for routine thyroid surgeries, as Dr. Ranil also mentioned, you just take a syringe, mesh it, and put it in the sternomastoid. It's just a 5-minute job. And every thyroid surgeon should be well versed with this procedure, which can actually prevent permanent hypoparathyroidism. So autotransplantation is a technique which all thyroid surgeons should learn and practice.
Yeah, there's another question. In case of recurrent laryngeal nerve injury, what is the current evidence on repair and recovery? I think we direct this question to Dr. Pradhan.
Thanks for the question. The major study for this is from Japan by Dr. Akira Miyauchi about the ANSA and the recurrent laryngeal nerve, which I happened to observe with myself there when I worked. And actually, they had it was a better voice they had post-operatively after this of the recurrent laryngeal nerve thing post-operatively. So if you cut it inadvertently and you can, you have the loops and all, you should stitch them with the micro, like around ethylon. We use nylon for this, and proline is basically used. I'm sorry, proline is used, and that's all.
So the recovery, how about the recovery rates?
Recovery rates are pretty promising from the study which we got from Japan. That's what I mentioned. So they said the voice becomes better. So the palsy is still there, but the voice becomes better. So this is what they mentioned there.
Can I add something?
Sure, sir.
Yes, sir.
Yeah, because what Roma says is absolutely right. So if you anastomose the ansa cervicalis to the stump of the recurrent nerve, what happens? If you don't have nerve supply, the vocal cord will atrophy. But when you have this anastomosis, the tension and the muscle of the vocal cord, even though there is some mixing, will be preserved, and that's why they have a better voice.
Thank you. There's another question. What about post-op management to prevent recurrence occurring? It's from Professor Arjuna Alvihare.
Question from the Professor Arjuna Alvihare.
Yes.
Yeah. What about the post-op management to prevent recurrence occurring?
There is I think the way to avoid recurrence is to remove the thyroid completely in the first operation, not necessarily post-operatively. Giving thyroxine and all may not be the answer. Most of the time what happens is the embryological remnants get left behind, like the sugar candle or the thyrothymic or the pyramidal lobe gets left behind. So those will recur. Giving thyroxine is not going to help. I think that may be what Prof is trying to ask, but the answer is no.
Right. That brings us to the end of the thyroid symposium. I must thank you, our speakers, Professor Amit Agarwal, Dr. Roma, Pradhan, and Professor Ranil Fernando for their excellent contribution to the Safe Thyroidectomy Symposium. I'm sure much of the audience benefit significantly from your information. Thank you very much once again on behalf of the College of Science.
Thank you very much.
Thank you.
Thank you.
See you, Amit.
Thank you, Ranil. Thank you.
See you, Roma.
Thank you, sir.